good therapeutic options for such a patient. So eventually we decided to put her on 60 milligrams of glycoside of modified release, and we have achieved quite satisfactory glycemic profile. Unfortunately, when we contacted her 2 weeks later, again her glycemic profile was much worse, so we increased the dose of glycoside to 90 milligrams per deciliter. But we don't know whether this is warranted therapeutic options for this kind of individual. Again, there is a basic question: should we leave her alone on diet only, or should we try to intervene with currently available treatment? So I would like to conclude that some cases of GCK MODY may be resistant to behavioral intervention. Pharmacotherapy may be warranted in selected cases of GCK MODY, but currently available treatment does not solve majority of our problems, so maybe glucokinase activators will be the treatment of choice in the future. Thank you very much. Oh, sorry, I have 2 more slides. I've forgotten about them. So the questions to be addressed, this is not I wanted to get twice your applause. So do we really have to improve metabolic control in GCK MODY? As it was mentioned before, the risk of development of microvascular complications of diabetes among GCK MODY patients is moderate. However, the long-term risk of the development of macrovascular complications is unknown. And now, at the very last slide, I would like to cite the paper by Andrew Hattersley. It concerns HNF3 alpha MODY. However, as you could see, some of our patients presented with relatively high HbA1c level, so clinically they may resemble to some degree HNF1 alpha mutation carriers. So Andrew Hattersley looked at the large cohort of British families with HNF1 alpha mutation, and he compared mortality, total and cardiovascular mortality, within families. He compared mutation carriers versus non-carriers, and he found that mutation carriers were at much higher risk of cardiovascular mortality. So this means that we should treat those patients whose metabolic control is not good enough more aggressively. Thank you very much.
Thank you, Tomasz. Has anyone got any comments or questions from the floor?
Comment concerning those obese individuals. Their HbA1c levels were about 7.3, 7.4. So this is definitely in the very upper limit of what you can expect as a result of GCK mutations. Moreover, this is at the level that is associated with the risk of vascular, also microvascular complications. And so I think that there is some, I would say, obesity-added HbA1c value in their cases. So I think that in such cases something should be done. And you have essentially 2 options. One is behavioral treatment, and this should be advised. And because, as I mentioned, there is some obesity added value here, I would also consider metformin. I don't know what you did.
Well, actually, we did nothing so far. We somehow hoped for good effect of behavioral intervention, but there was no effect.
No, you said we. I didn't see those patients.
Okay, me and Ivona. Actually, they are phenotypically identical. I mean, their faces are identical, and the way that they are talking about food is identical. So I would not expect too much effect as far as behavioral intervention is concerned.
Okay, thanks a lot.
Just from a practical point of view, what was your sort of behavioural intervention? What did you advise to them?
Well, we advise some calorie restriction. I mean, the modification of the quality of the diet would not be effective at all. They just told us what they like to eat, and this was it. So we advised some calorie restrictions, some more exercise, but to no effect.
In terms of the study that you'd done earlier in terms of low carbohydrate versus high carbohydrate, did you provide the diet for them? Or
yes, we did provide them with very detailed recipes. First, we took dietary history, and on this basis, not wanting to change their diet too much, we just did some modifications to obtain either 25 or 60% of calories coming from carbs.
I think the problem is we've got such little data on the effects of treatment and whether treatment is needed. And one study that we've quoted, although it hasn't yet been published, it's only been in abstract form, is in Exeter. Andrew Hattersley's group looked at the effects of HbA1c pre-genetic diagnosis when people are on different treatments, and then compared it to after genetic diagnosis, whether they're on tablet insulin or no treatment at all. And it seemed that HbA1c stays very constant, whatever treatment you're on, when you've got a glucokinase mutation. And that suggests that it's arguable whether you want to lower HbA1c, but actually it's very difficult to do it. And that's probably because of these people maintain regulation of their own glycemia. And it's hard to overcome that regulation even with treatment. So one thing is whether we can actually lower HbA1c. The second thing is what's the evidence on complications, and again it's not that good, but recently in Exeter they've been looking at people who are aged over 50 who've got glucokinase mutations, so they've been exposed to hyperglycemia for more than 50 years. And although they found a few patients who had background retinopathy, none of those people had had sight-threatening retinopathy that require treatment, and I think that's very reassuring. And they've got sort of similar data on microalbuminuria now, so people don't seem to be developing progressive microvascular complications. It's going to take a much bigger study to really get the answer on cardiovascular outcome. And I suppose where we don't have evidence, we've got to be pragmatic. And when we see individuals like your lady who had an HbA1c of 8 but could reduce it to 7 when she was on treatment, you know, we can't always rely on the genetic, on the patient having the genetic form of diabetes, we think, from the genetic tests. I mean, we've got the exact same case where someone's got a deletion of exon 10 in the glucokinase gene, but she definitely doesn't have glucokinase modi. She's on insulin and she needs insulin. So you've got to always go on what the individual situation is. But also, I think we do have to be a little bit brave where people do seem to have a classic glucokinase phenotype within the family. Even if their HbA1c is 7.5, we're probably not going to help them by pushing them onto treatment or dietary interventions. It's probably not going to make any difference.
Are there any other questions from the floor? Okay, thanks very much.
Thank you.
Okay, so now we are moving to